think we've reached critical mass here and we have a big and juicy topic to cover. So I'm going to get started. Welcome everyone to EHI's webinar. We've called it COVID-19 Vaccine Administration and Tracking, Understanding the Privacy Implications. This is a timely topic. This is in the news all the time. And I'm really pleased that we were able to gather today. And I'm really excited to have our illustrious panelists with us to help me think through and tease out some of these issues. I will start with some housekeeping and some introduction slides for those of you who may not be as familiar with EHI, and then we will turn off the slides so you can see everybody's beautiful faces and also mine. And we'll do our best to hit some of the, if not all of the questions that so many of you submitted ahead of time. That was very much appreciated when it came to shaping the agenda. You should all be muted. If you are not, please mute yourself. And throughout, we would love for you to submit any questions you may have in the Q&A box. Again, we've got a number of them ahead of time, so we've done our best to hit them in this presentation, but we'll try to leave some time at the end to address any that come in throughout the webinar. I am Alice Leiter. I am the Vice President and Senior Counsel at the eHealth Initiative. Again, welcome. And for this discussion, I am very happy to be joined by Chuck Curran, who is a principal of Charles D. Curran Consulting and has a very impressive background, which I'll let him tell you about next. We have Madeline or Maddie Gitomer from Hogan Lovells, my alma mater, and Karen Mandelbaum from Epstein, Becker, Green. So we've got lawyers, we've got policy experts, and I urge you to take advantage of this brain trust. As I said, we'll do our best to leave some time at the end for audience Q&A, which you should submit in the Q&A box. EHI is a membership organization, not to brag, but look at them. They're very impressive. If you would like to become a member and aren't already, let me know. Our work falls into three main buckets: education, advocacy, and thought leadership. And hopefully some of you have been invited to or have been able to attend some of the educational programs, expert roundtables, advisory boards, and work groups that we host and lead. We also issue recommendations, privacy policies, comment letters, largely through our policy steering committee. And the substance areas that we work in change depending on where we are in the world. But right now we're primarily focused on consumer privacy, virtual care, analytics, and social determinants of health. And obviously the only topic in the world right now, COVID-19. I will not run through all of these, but if you visit our website, you can see recordings and slides from some of our recent forums and webinars, our publications. And you can also see upcoming events and dates that we have. Hopefully you can join us for upcoming webinars and reports. They will be added to the EHI event page and EHI Resource Center as they become available. As I said, these are our panelists. I'm going to close off these slides soon so you can see them live and in person. And we're so happy that you're here. So let me stop screen sharing. And here we are. I'm hoping that each of the panelists, and I'll start with Karen, can just tell us a little bit about your background and your current work and how it relates to COVID, vaccines, and privacy issues.
Sure, Alice. Thanks, and good afternoon, and thank you for inviting me to participate on the panel today. I'm Karen Mandelbaum, and I'm a senior counsel at Epstein, Becker, Green, where I practice on the privacy, cybersecurity, and data asset management team. And I'm also the firm's co-lead on the Interoperability Focused Initiative. Before I joined Epstein Becker, I worked at the Centers for Medicare and Medicaid Services in the Office of the Chief Information Officer, and I was the Senior Advisor and Director for Security, Private, and Privacy Policy for the agency. At Epstein Becker, I advise healthcare organizations, payers and providers, employers, research organizations, drug and device companies on matters related to data collection and their use of data and how they share data, and of course, what to do in the event of an incident or a breach. During the pandemic, as businesses shut down and then had to figure out how to reopen, a good portion of our work has been devoted to advising clients on how to navigate the thorny questions about how contact tracing tools, what to ask employees and patrons when arriving, and what the best way to collect information is, and what to do with that information as they collect it are.
Thanks for joining us, Karen. Chuck?
Thanks, Alice, and thanks to EI for including me in this panel. My background is in this slightly different world of self-regulation and standard settings for the digital advertising industry. But in the past couple of months, I've been working on an open standards initiative called the Good Health Pass Collaborative, which is a collaborative effort from both civil society and also from the private sector to develop open and interoperable standards for digital health passes. And that effort includes the International Airline Transportation Association, the Linux Foundation, IBM, MasterCard. Travel is a focus, but the work is really designed to develop an interoperability blueprint for all of the use cases, including in arts and public stadiums and all of the instances in which a digital health pass might be displayed. And one thing I wanted to emphasize at the beginning is that digital health passes aren't necessarily just about vaccination information. It's really, in the context of COVID-19, it's information relating to prior testing by a lab or at home, prior evidence of prior infection, or obviously vaccination. So the discussion of COVID-19, quote unquote, vaccination passes really is more about a broader range of health attributes that can be contained digitally and transferred from one context to another. So looking forward to talking about all of the issues that go with that.
Thank you, Chuck. And that is helpful vocabulary clarification right up front. And last but certainly not least, Maddie.
Yeah, thank you, Alice. And thank you so much for having me here today, and to EHI for the work, especially in this past year on these issues. I'm Maddie. I'm a senior associate at Hogan Lovells, working for privacy and cybersecurity practice. Before that, I was working on capital of the Education, Labor, and Pensions Committee on the Senate side. Now focuses almost exclusively on health privacy. I counsel plenty of different roles in the health ecosystem, to name a few, like labs, research institutions, genomic companies, more traditional health companies working with health data. And so much of my work in this past year has been advising these clients on the response to the COVID-19 crisis, tested delivery of care, and now to vaccines and vaccine pass. The work has been, fairly quick turnaround times. Now there is an effort to think forward about how we are going to, ensure that privacy is contributing to and not creating an obstacle for public health efforts. I think there's often a perception that data hinders our ability to respond to public health events like the pandemic. But in fact, I think there's ways where strong data protection can increase trust and the ability to make progress in fighting diseases like COVID. So that's some of the thinking and work we've been doing at Hogan Lovells, and I'm excited to discuss these issues today.
Thanks so much, Maddie. I've said, I think at the beginning, that we deliberately titled and have framed this session broadly, because since the very beginning of COVID, there have been concerns related to data privacy. There were contact tracing apps in the early days, none of which were particularly embraced by at least the US public, due in part to privacy concerns. There were some relaxation of federal privacy regulations during the declaration of a public health emergency, which were not universally popular. And now there are concerns over who is collecting vaccine data, both at the source of the vaccines and then wondering about how vaccination status will be tracked. I was going to ask you each to talk about how your work has related to those various issues, but I think you did a good job of contextualizing it in your introduction. So I'll say that it seems to me that any type of health pass, a digital health pass, and Chuck, I'm grateful again for you level setting a little bit about what that is. The success of it will depend in part on consumer trust. And consumer trust really is an issue that underlies so many things as it relates to public health in general, but specifically with respect to COVID-19. Chuck, could I ask you to start with describing exactly what a digital health pass is. It's helpful to understand that it's not just a vaccine passport, but for those of us who need to sort of visualize what it is and what it will look like on our phone or somewhere else, I think that would be helpful.
Yeah, I mean, I think and visuals help, but I think the idea is that there's a health attribute that's created in a particular context, administration of a vaccine, and there may be data related to that that's held by a state or national authority, and then the ability to transpose that data to in a secure way that's tied to identity, to transfer it to, and I'll call this a health credential, to take that health credential and then to perhaps generate a secondary, what we'll call a pass, which is something which is derived from the health credential and allows for a user, probably with their phone, but possibly also with a piece of paper, to take some portion of, or some information from that health credential and transfer it in a way that it can be presented in other contexts. And that can be in a travel context, it can be in the context of entry to a stadium, it can be, you name it. The question is, what are the mechanisms that allow, that generate security, trust, and appropriate privacy across that chain of information? And obviously you have government or private actors, certainly in the creation of the health attribute. And then secondarily, you have, possibly governments, but in the main, the private sector then determining how that credential is presented. And it's that difference between those two different things, the original health information and the tool that's used to present it in a particular context, that I think allows for some of the privacy protection that we'll talk about in greater detail. But there's certainly, one of the questions is it's not necessarily the direct display of a person's personal electronic health record from one place and then just simply displaying it at the border or a record of prior infection or anything like that. So it's really about trying to find standardized ways and trustworthy ways that kind of information can be transferred.
Thank you. Very helpful. But again, this issue so it's helpful to have a visual and to understand how it would work, but that doesn't necessarily answer the question of how we, not to say to you, but to everybody, of how we shore up consumer trust in these technologies. And put another way, I know that all of you have experienced in the last year working with clients or individuals who are concerned about how this will work in practice and what privacy concerns there might be, also perhaps what equity concerns there might be. Karen, I know that you've had some experience in the employment context. I was wondering if you could talk a little bit about that.
Sure. Since many people, or if not most people, spend a good portion of their time working, employers have become kind of the front line or the gatekeepers of what the country's goal has been, and that is really to kind of get back to something that we consider normal since the pandemic began. And while guidance gets issued and things change both at the federal level and at the state level and at local levels, it's often confusing for employers to keep track of what it is that they're supposed to be tracking and supposed to be monitoring. I think that for the most part, when the pandemic struck, and people thought about the notion of shutting the country down, or shutting the economy down and shutting businesses down, that seemed like it was going to take a Herculean effort. But then reopening them has become even more complicated, and it seems as though there are constantly twists and turns that come about. And really the question becomes what is it? What information are employers collecting, and what are they using it for? in this context. And really, when the trust, when employees have to be able to trust that that in order to return to work, in order to come back to the workplace, in order to interact with whether it's other employees or the public, when they're serving the public, they have to be able to know that they are safe in their environment and feel comfortable in that environment. And so there's a trust, this trust issue, the question of how employers collect the information, what information they collect from their employees, how they implement the safety precautions that both federal and state and governments and public health authorities are issuing are really key factors to building that trust.
Thanks, Karen. Maddie, one of the related issues here that we've talked about is trust in technology more broadly. There's a difference between trust in a data holder that may be your doctor and a data holder that may be an app on your phone. And of course, that's related to the way that these digital health credentials will likely be operationalized. Can you just talk a little bit about the work that you've been doing with respect to non-HIPAA covered technology platforms and how that may play out in this digital health credential rollout?
Yeah, absolutely. And that's where some of these issues become even more broad than just privacy, right? It becomes really about data management and thinking through data sources and how we apply applicable legal frameworks to those, depending on who's holding the data and what data we're discussing. So, one of the things that we've been thinking about is for certain apps, right? So if an app was created and managed by, for example, a covered entity, right? If I got my vaccine at a hospital, it'd be very clear where I would need to go to get a record of my vaccine. Like, for example, if I lost my vaccine card, or if an app was requiring authentication that was more significant than just taking a picture of that card on my phone. But if I got vaccinated at, a community rec center down the road, or at a site administered by the city or state, or if I lost my vaccine card, right, where would I go to get access to the data that shows that I've been vaccinated, or that I've gotten a COVID test, or that I've had COVID in the past, right? Part of the challenge here is that there's many different players in the delivery of vaccines, and some are HIPAA covered entities, some are employers, some are government entities, and some are none of the above. And so how do individuals obtain those records? And then in addition, do they have a right to those records in each of those cases? And sort of in connection with that, we've spent a good deal of time thinking about how data is or is not covered by HIPAA. So, we're even where data may be covered by HIPAA, when we're, like Chuck said, transferring that data to an app, what's the permissible disclosure or pathway to get that data from within HIPAA to outside of HIPAA? And if it is outside of HIPAA, that circles back to some of the issues around trust that you mentioned earlier. So thinking through what laws may apply depending on the types of data we're talking about. Like Chuck said, I think there's a material difference when we're talking about trust, whether someone knows, like, you get a thumbs up that you can enter an arena, or whether you know the date of their vaccination or why they specifically weren't able to get a vaccine, right? Those are different levels of sensitivity of information, and whether the stadium that you're entering is somehow maintaining that data. I think in most cases the answer may be it's not, but those are going to be important questions that will go ultimately to whether folks trust these types of technologies.
Well said. I think also there's an equity angle to this too on the topic of trust, because different populations in different parts of the country and of different races and socioeconomic backgrounds and geographic locations feel differently about the healthcare system in general. We've obviously seen pronounced disparities in the way that COVID has affected and been handled across different populations. I think there's some equity issues too, as it relates to both vaccinations and the tracking of those, depending on who's doing the vaccinating. Can any of you speak to some of those that you've seen or have thoughts on?
I'll just say that it's certainly, I think everyone recognizes that it's premature to have any discussion about the widespread use of digital health passes, certainly that relate to vaccination status, when there are disparities by race or by socioeconomic barriers to the access to the underlying vaccine. Then there really can't be any discussion of widespread expectation of use of these passes. One tie-in, however, is that once you do get to that threshold where, from an external perspective, governments determine that that it's appropriate, or that they will allow the private sector to make use of these technologies for private activity, there are still issues as well with the sort of the questions of access to digital technologies. There's an equity issue there, and paradoxically, certainly for if you're thinking about trying to bind digital identity to all of this, there are some challenges. If you're thinking about the undocumented, a population that is, the focus of a lot of the public health efforts in connection with COVID, to be overly reliant on digital technologies and health passes when they are essentially too identity driven to accomplish the public health purpose that is envisioned. I think that the rest of the concerns remain then in how the things that are then, from a trust perspective, actually executed and governed with appropriate privacy protections, and that's what governs the actual use and who keeps what data for what purposes in what contexts, depending on whether they're used for the employment setting, for public life, or for international travel.
Thank you. I think that was exactly what I was hoping you would say, because one of the questions that came in advance was, why wouldn't we require proof of vaccination upon entry to any number of contexts? And there are some really good reasons. If you tie entry in general to places or access to services to a digital credential, that by definition may exclude a series of populations. And Karen, as you were saying earlier, it also has employment discrimination implications as well.
Yeah, I was just going to add also that, many of the, especially in the employment area, most employers that we work with often come to the critical question of, what about employees that don't have access to a cell phone or something like that, or don't have a smartphone, right? Or that have a disability that make it difficult for them to use that type of technology in the first place. There are many reasons that make access to that kind of technology a challenge for many employers, and then operationalizing a way of processing and managing those employees becomes even more difficult and creates an even greater sort of difference between those that can use the technology and those that cannot.
And Alice, can I add one quick, just to build on what Chuck and Karen both said? I think, Chuck mentioned the types of events for which we're going to be using vaccine passports. And I think that's a really important question, right? That needs to be answered and will be answered in the coming months, right? If there is risk that we would, in order to participate in society, need a vaccine passport, that's, a different, that's a different equation than, for example, if we're only using it for example, concerts, right? But if you need a vaccine passport to go to your grandchild's school for an event or to church, that's going to be, that's going to really hinder the ability to take part in society. And the second thing I'd note is just that if this sort of goes to trust, but also to equity, to the extent that individuals, that these individual apps are logging where these passports are used, I think that's going to be an important consideration. So for example, if health systems are requiring vaccine passports in a certain way, and a third-party app may know that you are going to a health facility that specializes in drug treatment or reproductive care, that has privacy implications from an equity and from a trust standpoint.
I'm so glad that you all are in charge of figuring this out, because it's certainly complicated. We got a number of questions sort of specific to the digital health credentials themselves that I think Chuck has mostly answered, but a lot of people had questions about when we think a rollout of one of these or more of these may be. Would the public have any way of having access to this information, or would it be strictly private between the venue collector and the individual? What information beyond vaccine status is in one of these? Again, I think, Chuck, you spoke to that. And, you know, if there are any parts of those questions of the sort of hows and whens and whys that we haven't covered that any of you have answers to, I know our audience would be grateful.
That's pretty complicated. Oh, go ahead.
I mean, we have, you know, largely from the international context, we have the Israeli Green Pass, which obviously is a country with very high vaccination rates, and it's, you know, it's important to stay focused on use cases, at least as we read about the Green Pass. It seems to be largely used in the domestic context for access to clubs, restaurants, gyms. So it has the characteristics of sort of something that's very, very high frequency. It's a pass that's issued by a national health system. So it's relatively, there aren't that many hops between the creation of the medical record and the creation of the QR code that's displayed for this frequent event of going to, you know, moving around in domestic society. But I raise the issue of frequency because it really does determine a lot of the characteristics about who gets to store what. You can imagine international travel more frequent in Europe, maybe a little less frequent in the US. You know, the employment context and the going back to college context, the presentation of information relating to health status is maybe, you know, close to a one and done. It's not you know, not necessarily something that is, you know, requires a digital health pass, right? You have the potential to present information in kind of in the way that you did previously relative to other, you know, your meningitis vaccination in the college context. So you know, the question is, in the context of how frequently, to Madeline's point about when and where and how often you're presenting this, I think that's the place where you really ramp up the concerns about attention to need and necessity of really having any personally identifiable information. And so I think Maddie captured that point. It can be simply non-personal information that the bearer of this QR code is in green status for whatever the defined rule set of criteria for that particular venue, so that you really take, you completely separate and wherever possible decentralize the storage of information relating to the, you know, essentially meeting with a checkbox the health status that's required in that context, especially where your frequent activity generates that sensitive location information history of where you've been and who you've been presenting to.
Other thoughts from Karen or Maddie?
Well, I think that what you're saying, Chuck, is really an interesting idea, and it kind of brings us almost like to the discussion about or asking the question about interoperability. I think that what you're describing is separating the data from the application, right? And having, you know, whatever underlying information about the individual separate from that QR code that gets displayed, right? And that's really a key factor in being able to, to identify the passability, or make the technology really do what it's supposed to do, without doing all the sort of behind the scenes linking of information that is so often the cause of the privacy issues and privacy concerns, and also brings that data into a sort of a situation where it can be accessed by people that shouldn't have access to it, whether it's inadvertent or purposeful, right? So it kind of builds that layer of protection in when you separate that data. And I think that the example of sort of the countries that are able through the national health systems to be able to coordinate those types of efforts is a good use case for us to consider. But be that as it may, here in the United States, we always seem to be dealing with that patchwork of and complexity of our laws and regulations that make things a little more complicated. And I think that to bring Maddie's discussion about sort of the frequency that people may have to be checked. There's that idea of seeping, right? So if this stays at a high level where it allows people to or where passports are used, like just in certain circumstances or under certain for certain activities, it's one thing. But if it seeps into our absolute everyday maneuvering and participating in society, it becomes really an incredible burden, and it really becomes sort of the way that we don't get back to normal.
Well, that's a perfect segue into what I was going to ask next. I am pleased that you all on the panel are legal nerds, and it seems like many in our audience are as well, because we got a lot of legal regime, data governance, HIPAA, state law questions. We don't have 6 hours and thousands of dollars to pay all of your billable rates to answer those questions. But what are the legal regimes that are going to govern vaccine data or vaccine passports, digital health credentials? I assume, as Karen, you said, it is very complicated because there'll be states that do one thing and states that do others. States have sometimes overlapping, sometimes conflicting laws. There's HIPAA, there's then the FTC for non-HIPAA covered health tech apps. Again, without writing a 23-page memo on the fly, any thoughts on how we're thinking about this from a legal governance perspective would be great.
Maddie, do you want to go, or you want me to take the first stab?
I'm happy to give some initial thoughts, but I think there's, like Alice said, there's plenty to discuss here. I think the answer is somewhat unsatisfying in that it's going to depend on who's holding the information. Some of this is about push and pull, right? Is information being pushed to someone, or is it being disclosed to the user themselves, right, through maybe a HIPAA directed disclosure, or is it a disclosure to another vendor or another third party? And if so, how are we getting it outside of HIPAA? But is it governed by HIPAA to begin with? I think those initial questions, right? I think initially the question will be, is the information governed by HIPAA? And is it held by a covered entity or business associate or a third party? And if it's a third party, why is it not covered by HIPAA? Once the information we determine is not covered by HIPAA, right? We're all familiar with HIPAA, but once it's not covered by HIPAA, we have to think about laws like the CCPA or Virginia's new state law. And then I think we need to think about, of course, the FTC. So for example, like Karen said, there's a lot of interoperability issues here. In the past 2 years, interoperability has been a huge issue in the healthcare space, right? With the new rules just becoming effective at HHS this year or this month. They may not be directly applicable in all cases here, but what we know is that the FTC was very interested in the protection of that information. Congress was very interested in how that information disclosed pursuant to those rules would be governed. And I think we have the same issues that arise here. So I think the FTC is going to be involved. AGs are certainly going to be involved in enforcing consumer protection laws and privacy laws. And then you have HIPAA. And then from an interoperability standpoint, if some of this data is maintained in EHRs that are governed there, I think we're going to have some of the same issues that we've seen with respect to the interoperability rule. So I think there's no shortage of legal frameworks that may apply, and that's just in the US.
And I think you're right, Maddie. And to say nothing of the fact that that the extra sort of the outside of HIPAA entities that will certainly be involved in some way, shape, or form. I think that we can't forget I'm sort of speaking out of turn because I kind of feel, Chuck, like this is your domain, but that sort of self-regulated framework of just simply doing the right thing and not using information that is medical, healthcare related, right? Like whether it's, the FTC certainly is, applies, and the FTC rules certainly would apply since we're talking about electronic data, but we definitely can't forget just sort of the self-imposed or self-inflicted requirements to treat this data as the sensitive data that it should be considered.
Well, I just have to say, entities to look at self-regulatory frameworks like e-health initiatives, health principles, which are actually, in the context of health passes, a useful tool set. And I'll just add two other quick points. One, when you talk about interoperability, at least in the international travel context, that means you are answerable to the highest standard of data protection, which means welcome to GDPR world. There you really get into the question of sort of international baseline privacy requirements for a truly interoperable tool. That may not be, obviously, for purely domestic digital health passes, not a question, but it's certainly something ultimately for if you're trying to use something from one context and then another, that has to be factored in. One other interesting thing about pandemic specific data has been the focus on regulators on sort of limited lifespans and data that's tied to the lifespan of the pandemic. If you followed last year's introduction by some of the Democratic senators of the Public Health Emergency Privacy Act, you saw this notion, and this was largely tied to the exposure notification apps with all of the powerful data that they have about location and proximity. But the notion there was that 60 days after the Secretary of HHS declares the end of the pandemic, you are supposed to delete all of this data, right? And that concept of emergency data only has been echoed in the European Data Protection Board has issued its preliminary evaluation of the European version of the Green Pass or the Green Certificate or whatever it's called, and has similarly raised the notion that when the pandemic ends, so does your data. So how this squares with the long-term retention of a vaccination credential, the scientific significance of a vaccine in the first half of 2021 of a particular type of vaccine and what that means a year down the road is another question. So there's a certain instability of the underlying, these are, not only scientifically potentially unstable data, but, there may be sort of specific regulatory limitations placed on certainly the data and possibly also on the apps and technology that if that's the only thing they contain, then the apps themselves having a lifespan. So that's just something to consider in terms of what's how much of all of this is emergency only.
Really interesting points. Thank you, Chuck, for the plug for the EHI CDT consumer privacy framework. I do want to just say one more time that this is a framework, a set of data principles and accountability mechanisms that is specifically designed to address even in the non-COVID context, the issues of underprotections for health data once it leaves the health system and therefore loses its HIPAA protection. We did not start the project in the context of COVID, but it certainly gave us a little bit of a boost toward relevance and urgency. And I urge you to read it tonight before bed. It'll put you right to sleep. One of the other things, though, that's relevant to that framework is the absence of a comprehensive US data privacy law like the GDPR, which Chuck just mentioned. I wonder, just with you all being savvy insiders with your ear to the ground, have you heard to what extent maybe this concept of credentialing or vaccine status tracking has played into discussions on the Hill or momentum building for a law like this? There was a lot of momentum the year before the election, and then that was just sort of a crazy period for a number of reasons, but I anticipate it starting back up again. So any insights there? I guess not. So if any of you insiders on the phone want to tell us what you know, I think it's coming, and I wonder how different this conversation about legal protections and data governance and provenance would be if we had a law like that.
Yeah, and Alice, I can just say a few things. I think Chuck's point, I think, was an important one. I think we see the federal government with COVID-specific data starting to think about whether there should be federal involvement in how long, for example, this data is maintained or whether there are limitations on its use. And I do think that sets the stage for broader actions. But, it's also difficult to tell whether that movement is because of COVID or because increasingly states are now passing different regimes and or legal frameworks, and companies are trying to juggle, particularly in the health space, so much right now that having to figure out which of numerous state and federal frameworks apply and how they can comply is getting really time and resource intensive. And so I think it's unclear whether COVID or that legal landscape or both are contributing to an increasing, I think, likelihood that this will happen.
That's a good point. And having spent many a midnight hour doing 50 state surveys with Maddie at Hogan, I can only imagine how much more time and labor intensive that's become. I'm happy that you guys will not be out of business anytime soon. I wonder if there has been work that your firms have done, Maddie or Karen, specific to the sharing of lab results. A question has come in about whether or not there was inhibition of the sharing of COVID lab results with primary care and health information exchanges. And that's something that I've heard in previous months too, that the sort of lab data sharing has been an issue. Any experience with that?
I think that, it was very encouraging when the state of New York issued it, or when Governor Cuomo issued his executive order that that required clinical labs as part of their CLEP program in New York to join the SHINY, the Health Information Exchange in New York. And so a number of clients did fill out those applications and did enter into the agreements to share information through one of the HIEs in New York. And so, but it seems as though clinical labs still kind of put themselves at the periphery, even in the interoperability context, where they're considered covered entities. They're considered healthcare providers under the definition that ONC has adopted for the actor that is the healthcare provider. But there seems to be a reticence, and it's I think you're making a good observation. It's a good observation that that data, it still kind of remains at the periphery of the healthcare ecosystem.
Yeah, I think this is an issue, if I may, Alice, quickly, just that we've done some thinking about, I think I'll just mention two areas. The first is, I think there has been much more coordination necessarily between, the CDC and public health agencies and labs than I've ever seen before. I think particularly lately, where we're tracking variants, labs have been, I think, critical to that effort, and working really closely with government entities to ensure that we're tracking variants and the spread of COVID more broadly. On the flip side, I think one of the challenges that I see other entities facing is the idea that all COVID tests, or I shouldn't say all, but in many cases, COVID tests are shared with governmental authorities to track the spread, right? So this gets back to where we started, which is patient and individual trust in the process. And right, the government has said, for example, on vaccine passports, at least right now, the federal government has said, we're not going to play the central role. But in testing and tracking the spread, government health agencies, that they are critical to that effort. And I think folks do have concerns. Some folks have concerns with them obtaining that data for public health purposes. So again, this is where education and transparency are really important to maintain that trust. But labs are sort of in the middle of all of that, navigating, responding to a public health crisis, but also ensuring that people are obtaining tests when necessary and getting their results quickly.
I would add one other, just to echo part of your point of the sort of the federalism and the patchwork issue, which is, there's been activity in the states, an executive order in Florida by the governor prohibiting the both the Florida government from quote unquote issuing such a thing and issuing a digital health pass or a vaccination passport, as well as prohibiting private business from requiring their presentation. Certainly if you have the primary locus of vaccination information in a state database, an immunization information system, you have tremendous, at least at the state level, the ability to throttle or cut off major data sources that could, in effect, to turn off the provisioning or at least the easy provisioning in an authentic or in a verified way of at least the vaccine component of that, and so you end up with sort of secondary proofs with people presenting their paper credential to some second level verifier in order to if it is even legal for a private sector entity to accept the proffer of a health pass. So in contrast to many national health systems, you have you have the complexity and really the stronger hand of the states possibly over whether these things will ever fly, or at least a legally enjoyable patchwork of and a design data architecture challenge of figuring out in which jurisdictions data can be entered relative to these credentials.
Thank you all. A question has come in that, Chuck, I wonder, is somewhat related to that, if you know the answer to. Do you know any role, is there one that the US federal government will play in setting a digital health pass technology standard?
At least the most recent statement from the White House was that very clearly there will be no federal database to support this, that guidelines are coming. I think that's the, for now, where while the focus is, and rightly so, on the vaccination process.
All right, I'm looking down my question list. Thanks to all of you who've submitted it. I'm really happy we have a little bit of time at the end. A question about the significance of the emergency use authorization, which says people have the opportunity to accept or refuse the COVID vaccine. For Maddie or Karen, maybe any issues that have come up in your practices about how this right will intersect with vaccine requirements in certain places or in certain settings?
Well, in the like I said earlier, in the employment setting, employers are facing, the instances where employees are refusing to take the vaccine for a variety of reasons. In the hospital, in the healthcare setting, healthcare workers are also often doing the same. And for the variety of reasons that that employers have to comply with other employment state and federal employment laws, they really don't have the option, I guess I would say, to mandate it beyond the initial mandate, right? Like there have to be those exceptions. I mean, there are people who will, for a variety of reasons, and they include that they have a firmly held religious belief, that they have an allergy or a reason or a physical reason why they can't or shouldn't take the vaccine, whether it's like I said, whether it's an allergy that's documented or it's an opinion that based on other medical conditions or things like that would excuse somebody from having to take the vaccination. That all said, employers are left with the struggle of figuring out how to reasonably accommodate those types of employees without creating an environment where discrimination might flow from it. So it's this isn't something that's new. It's not, but we're at a crossroads where, without knowing specifically what the efficacy of the vaccine is long term. I think that what we might be waiting for, initially the CDC's recommendation was that you wait 2 weeks after the last vaccination is administered, and then 90 days, but that 90 days has been lifted. I guess what we might be waiting for at this point is, some further guidance or further information, as to whether there's a booster on the way or annual vaccinations that resemble a flu shot. And if we get to that point, to your point earlier, Chuck, being able to lift the public health emergency and the emergency use permission, right? Like to use these vaccines in this state, we may end up in that world, which will really just sort of re-level playing field, and new policies will come into being as to how to deal with that scenario. So I think that it's a constantly evolving, constantly changing landscape that's hard to anticipate.
Yeah, I can envision all the law school case studies that are going to come out of this. Karen, I don't mean to pick on you again, but one question came in that I remember we talked about a little bit in our prep for this panel, and that is that all of the COVID vaccines, I think, are still conditionally approved for emergency use, and that therefore they're maybe considered still effectively a clinical trial rather than one of the more traditional vaccines that you were just talking about. Can you remind me your brilliant thoughts on this topic from last we spoke?
I don't know if I would call them, right? Because this is such an esoteric sort of spot in the law, right? Like, so there are vaccines, and then there are countermeasures, and there are programs that cover those different types of treatments. Because they're either injuries that flow from vaccines are treated differently than other types of injuries that flow from other types of healthcare or medical interventions. And so the COVID vaccine, last time I checked, was still considered a countermeasure, has not achieved vaccine status yet. That's tied to a CDC determination that both children and pregnant women are recommended by the CDC to get the vaccine / countermeasure. But those things have, right, like that hasn't happened. I've anecdotally heard about testing in children under the age of 16, but I haven't heard that the CDC is approving those uses. It's all then tied to the declaration of the public health emergency, and then under the declaration of the public health emergency, the Secretary of the Department of Health and Human Services can and has declared that that the emergency use is available. Presumably, if the public health emergency is lifted, that emergency use would go away, and the actual clinical trials for these vaccines would either have to be implemented, they'd have to do them, or this would serve as the trial, right? Like we've vaccinated millions of people already, and I guess this could serve in some fashion as a trial. We just, in between the time that we spoke and now, we watched the Johnson & Johnson vaccine kind of hit pause. So, and I scrambled to sort of see what I could find at that time, like when that happened, and no one really talked about it. So I don't know. It's not a great answer, but kind of my look at what this all looks like from my vantage point.
Yeah, that's so interesting, and lucky you that you get to be answering these questions in real time for paying clients, unlike myself. We have just about 2 minutes left, so I'll ask any of you if there are any concluding thoughts or anything that we missed in what I thought was a really interesting hour. And hearing none, I think we covered all the questions we got in advance and most of the questions that we got during the course of the webinar. So I'm really appreciative again of our panel for joining us, but also for being so quick and on the fly with your answers. I learned a lot, and I hope this was valuable to all of you at EHI. A recording will be posted on the EHI Resource Center shortly, along with contact information for me and my panelists should you have burning follow-up questions. Thank you all for joining us, and thanks in particular to the panel. Have a good afternoon, everyone.
Thanks.
Thanks, Alice.